Good afternoon, Mr. Chairpersons, the eminent senior neurologists sitting in the hall, and dear delegates. At the outset, it's my privilege to be part of this wonderful academic event, and I convey my sincere thanks to Dr. Arun Garg. My topic for today is Rituximab. Is this the answer to all autoimmune roadblocks? I shall begin my talk after paying respectful tribute to my late guru, Padma Shri and BC Roy awardee, Dr. Ashok Pangaria, and also to the Calcutta incidents victim, the incidents which shook the entire country. Coming to the topic, neuroimmunology, it is an interdisciplinary field that explores the complex interactions between the nervous and the immune systems. Initially, CNS was considered an immune privileged site due to the presence of blood-brain barrier, but recent studies have demonstrated that immune cells such as microglia, astrocytes, and peripheral immune cells play crucial role in maintaining CNS homeostasis and responding to injuries and diseases. This is how the B cells contribute to autoimmune response. From stem cell, there is creation of pro B cell, then there is pre BCL, then there is immature B cell, and all have different transmembrane antigenic proteins. Then there is pre BCL, then B cell can convert to plasma cell or can get converted into memory B cells having different transmembrane antigenic receptors. How B cell contributes to autoimmunity is it processes and presents autoantigen to T cells, and it can produce cytokines like IL-4 and IL-10, and their maturation finally into plasma cells can lead to production of autoantibodies. Coming to the review of literature of MAPs or monoclonal antibodies, the production of monoclonal antibodies was first described in the year 1975 by using hybridoma cells. Hybridoma cell is development of a clone of plasma cells with the lymphoma cells. The first MAP approved by FDA for human use was a murine anti-CD monoclonal antibody, which was called Muromonab OKT3, and it was used for the treatment of organ transplant rejection. Rituximab is the first generation. It is a mouse-human chimeric. Chimeric means that this term is taken from a mythological creature in which the body contains two elements, the lion and the goat. So this is how we can describe the structure of rituximab, and this is directed against B cell lineage marker CD20, and it was first to be approved in the year 1997 by FDA for the treatment of relapsed or refractory CD20 positive B cell lymphoma, low grade or follicular non-Hodgkin's lymphoma. These are few maps. We can see that this first one is totally murine, and this has both the portions from murine origin, FAB and FC, whereas, and this is called OMAB. Second one is chimeric. Chimeric, as I told, mixture of two structures. The green part is murine and the blue one is humanoid. Third is humanized map. The chimeric is also called rituximab like ZMAP, and then humanoid is called ZUMAB, and this contains only 10% part from murine structure and 90% from human. This is called humanized, and last one is completely human, and this is called UMAB. So this is the history of monoclonal antibodies. The first generation is rituximab, and then there are many. Most of them are directed towards multiple sclerosis treatment. Some are for NMOSD, then myasthenia gravis, and the last one, lecanemab, is for Alzheimer's disease. So the rituximab is a widely used B-cell depleting IgG1 chimeric monoclonal antibody. It was developed by IDEC Pharmaceutical first under the name IDEC C2B8. Then in the year 1997, it became the first monoclonal antibody to receive FDA approval in oncology for non-Hodgkin's lymphoma. Subsequently, we got FDA approval for refractory rheumatoid arthritis and ANCA positive vasculitis. So what is the mechanism of action of rituximab? It depletes CD20 plus B cells via three different mechanisms. One is antibody-dependent cellular cytotoxicity mediated by FCY receptor on the surface of NK cells. Then macrophage. Third thing is complement-dependent cytotoxicity, and lastly through apoptosis. This is how rituximab depletes B cells. And in 3 days after you give rituximab, 90% of the B cells are depleted, and in 15 days almost entire pool of B cell is depleted. So what are the indications of rituximab in neurology? I can tell you it is still not FDA approved for neurological indications, but it is unlicensed, off-use label, and it has been found effective in many conditions like relapsing remitting MS, and it is used for the maintenance therapy for relapse prevention, then NMOSD as maintenance therapy, in autoimmune encephalitis for acute use, primary angiitis for acute therapy, then immune-mediated peripheral neuropathies, and myasthenia gravis and stiff person, all in refractory cases. The other indications for rituximab are ANCA-associated vasculitis, SLE, recurrent focal segmental glomerulonephritis, then membranous nephropathy, CLL, and refractory rheumatoid arthritis. Side effect profile, it is a relatively safer drug, and the highest risk is with the first infusion. The most reactions are mild like headache, pruritus, throat irritation, flushing, rash, urticaria, hypo or hypertension. So on the day of infusion, one should always check blood pressure of the patient. Then there can be severe or life-threatening anaphylactic infusion reactions. After 3 to 6 months of the treatment, neutropenia can be seen, and other complications are PML and PRES. Recently, few studies have shown that there is flare-up of COVID-19 cases also during the infusion period, but these COVID cases are relatively mild and they do not necessitate ICU care. The contraindications are hypersensitivity, acute, active severe infections like TB, sepsis, and opportunistic infections, severe immunocompromised state, and the cardiac cases like severe heart failure and uncontrolled cardiac disease as it can precipitate MI and arrhythmia. You have to be relatively cautious regarding use of rituximab during pregnancy and breastfeeding, and one should always undergo a pregnancy test before starting rituximab, and use effective contraception during treatment with rituximab and for 12 months after the last dose of rituximab. Do not breastfeed during treatment and for the 6 months after last dose. Workup is mandatory pre-treatment workup is full CBC, LFT, HBV, HCV, HIV serology, and routine urine test. And then elective pre-treatment is that few precautions you should take care, that give non-live vaccines 4 weeks prior and live vaccines 8 weeks prior to the first infusion. Also give pneumococcal vaccine to all the patients, test for latent tuberculosis and varicella zoster serology. How do we administer? 500 to 1 gram on day 1 and 15, and then repeat 1 gram every 6 to 12 months, depending upon the B cell count. Another thing, in autoimmune encephalitis, since it is an acute therapy, so one can follow this regimen 375 milligram per meter square body surface area weekly for 4 weeks only, and give IV MPS and pantoprazole prior to each infusion. There are 2 studies in the year 2011 and 12, and these studies have revealed how do you monitor the fresh or the next dose of the rituximab. It depends upon the B cell count. So the B cell count should be done monthly according to Greenfield, and you retreat with single 1000 milligram infusion when it rises above 1%. Another study says that monitor memory B cell population 6 weekly in the first year, 8 weekly in the second year, and 10 weekly thereafter, and retreat with 375 milligram per meter square when it rises above 0.05% in first 2 years and 0.1% thereafter. In various neurological diseases, there have been landmark trials like in myasthenia, RIMA trial in 2021, which says that MuSK positive myasthenia is very effective. Then BEAT MG trial in the year 2020, and recently Rhinomax trial in the year 2021, which says that low dose reduces the need of rescue drugs with minimum myasthenia gravis symptoms and also is better and safer. Then in multiple sclerosis in the year 2008, Hermes trial, and it says that it reduces disease activity in RRMS, whereas in PPMS results are inconclusive. Then in NMO, autoimmune peripheral neuropathy, refractory ones, and autoimmune encephalitis, there have been trials on rituximab. How it is different? Rituximab is first generation chimeric monoclonal antibody, but there are better options available now like ocrelizumab, which is a humanized one, then ofatumumab, and then third generation obinutumab. So these are the other options, but rituximab has a better safety profile and it is cheaper in comparison to these therapies. Well, we do not have any study from our center, but this is our preliminary experience in 12 cases, and there are 4 cases of myasthenia, 5 cases of multiple sclerosis, either SPMS or RRMS, then 2 cases of inflammatory muscle disease, and 1 case of NMOSD. And we have used rituximab only as second line drug, as rescue drug, where 2 to 3 drugs were ineffective. And we found that in preliminary study, the drug appears promising. There are many Indian studies, and from 2016 to 2022, and 2 important studies from Maharashtra. One is by Dr. Satish Nirhale and Dr. B.S. Singhal and Dr. Varsha Patil. They have used this rituximab in all cases of demyelinating disorders, and the study results show promising and the positive response for rituximab use even at off-label or non-licensed stage. These are Western studies. So the future is that rituximab is emerging as a novel therapeutic option in several autoimmune neurological disorders. The randomized clinical trials already conducted do not only show clear benefit in RRMS and in anti-MAG neuropathy patients, but they also help us understand the ongoing immune deregulation and the role of B cells in these disorders, especially multiple sclerosis. The rituximab points to a new, more targeted and effective immunotherapy for the treatment of various chronic autoimmune neurological disorders, including IgG4 CIDP. So the take-home message is, it's a chimeric monoclonal antibody and it is directed against CD20 antigen on the surface of immature and mature B cells. It is used off-license to treat a variety of immune-mediated CNS disorders. It is safe and well tolerated in most. The long-term use may be complicated by hypogammaglobulinemia, and this requires screening also, and increased infection complications. The optimal dosing is still unclear, It depends upon different diseases. Like in acute conditions, it should be given every weekly for 4 weeks. In other cases, one has to give maintenance dose depending upon the B cell count. With this, I conclude my talk and convey my thanks.
Thanks, Dr. Bhawna, for wonderful presentation. I think a very comprehensive presentation. I request all three speakers to please make available for some questions. Although we are getting late, we'll take a few questions. I'll ask Dr. Bhawna, how will you compare with immunoglobulin, IV immunoglobulin efficacy to rituximab in your experience in these kind of neurological conditions, and also whether you used IVIG before or you use rituximab before that?
Rituximab we always use as rescue drug or the second line drug. In autoimmune encephalitis, first drug is IV MPS, then we switch on to IV IG, and if not, then we switch on to rituximab. In other cases also, like those cases of myasthenia, they were getting 2-3 immunosuppressants and were given IVIG. But still, the disease kept on flaring every few days. So we started rituximab in those cases and it was found to be effective. Third is MS. In MS also, although it is an off-label drug and there are better options available like ocrelizumab, which is FDA approved in the year 2017. But still I feel this is a cheaper and better option.
There's a better safety profile also as compared.
Yeah, side effect profile and the cost.
So Dr. Kathak wants to ask.
Mike,
I think, Bhawna, you must add nodopathies, paranodopathies to your long list
Yes, sir.
of immunological conditions which respond beautifully to rituximab.